Good evening. Welcome everybody to our pre-session pre-legislative session town hall. It's great to be with everybody, even under these crazy conditions. But anytime I get an opportunity to interact with constituents, it's truly an awesome opportunity, and I look forward to these nights. First, I just kind of want to give you the gist of how we'll conduct this. There'll be a whole bunch of questions that we're going to get to at the end. But we're going to have a short brief about Five and Great Mills and that project from State Highway, followed by Dr. Wilbur Chen and our very own Dr. Mina Brewster from the Health Department regarding COVID and the vaccination distribution plan. And then we'll get to the bills that we're going to propose here in Annapolis during the next legislative session. First, I just kind of wanted to answer a general question that was posed is, what does session look like, and will we have a session? And yes, we are going to have a session. All the legislators will go up to Annapolis. We are going to be tested before we get up there. There'll be some testing throughout when we return. But for the most part, it is going to be a normal legislative session. Now, there will be some differences. First, not everybody is going to be on the floor of the House at all times. There's going to be, I believe, 71 members on either in the floor or the gallery. So they will be adequately distanced between each other. And then we will also have annexes set up in the House building where the office is across the street, which I will be sitting in almost like a enclosed plastic casing. And I'll be following along just like all of you via Zoom. The only difference is I'll still be voting on bills. So there will be ample opportunity to make our arguments and then make counterpoints, propose bills. All of that will still take place inside the chamber, and I look forward to it. As many of you know, in the morning, we have legislative session, which everybody typically thinks of when they think of the legislature. But in the afternoon, we have committee, And so committee is really where we fine-tune policy in small groups to make policies in the state of Maryland better for each resident. And it is where my light just shattered. It is where, we really get into the nitty gritty of each and every policy. So you will be able to follow along as we are in, committee hearing bills that come up. And I will tell you, we are going to do that virtually via Zoom, just like we're doing this. So I'll be seeing the same exact thing you'll be seeing at home. And if there's a particular topic or bill that piques your interest and you have questions, feel free to shoot us your question online, or via our email, which is up on the screen. It's brian.crosby@house.state.md.us. And then, we can ask that to the panelist that is up there briefing, so that way we can make better policy and it gives you more civic engagement into the overall process. But again, I'm super happy to have you all here this evening. You can post your comments or questions in the chat section. We have several people that'll be following along, myself included, where we can kind of screen the questions to make sure we ask our panelists. But with that, I am going to start with the Five and Great Mills project. We are lucky tonight to have a few members from State Highway, the State Highway Administration. First, we have Deputy Administrator Jason Ridgway, District Engineer Corinne Johnson, Highway Development Director Eric Marabello, and my friend, Legislative Affairs Manager Mitch Baldwin. So with that, Mitch, I'll let you kind of take it, from here, just kind of give people an overview of the project itself, and then where we're currently at and kind of what the timeline looks like going forward.
Thank you, Delegate. So I will pass it off to Deputy Administrator Jason Ridgway, and he, Corinne, and Eric will provide the updates for you. Thank you.
Great, thanks, Mitch. Thank you, Delegate. Good evening, everyone. I'm Jason Ridgway, MDOT State Highway Administration Deputy Administrator for Planning and Engineering. And it's a pleasure to be with you all virtually this evening to give you an update on the Maryland 5 Great Mills project. We have a visual up there to help us kind of walk through that, which is perfect. First, I just kind of want to acknowledge that we know this is a very important project to the area and to the county. And I also want to let you know that it continues to be a very important project for Secretary Slater and Administrator Smith, my boss. And, this is a great project for mobility and operations, as well as accessibility in the state of a good repair. So the improvements there, as you can see, it includes additional lanes in each direction, including turn lanes. It also includes a bridge replacement and some bicycle and pedestrian accommodations and sidewalk. This project is currently fully funded for design in right-of-way. And we are currently progressing our design. Our design is about at 60%. And we're also progressing with
Hey, Jason, I don't know if it's me, but it
Yeah,
sounds
I
your
think you
audio
muted
cut
yourself, Jason.
design in the right of way. Assuming we can get some funding for identify that funding for construction and
Hey,
utility.
Jason, not to cut you off.
Sure.
Can you go back a little bit? You maybe like 20 seconds. You kind of cut out there audio wise.
Okay.
I don't think anybody heard you. Sorry.
Yeah, no, I apologize. So I don't know where I lost you.
I think basically just saying that you just talked about the additional lanes and the bridge.
Oh, got it. So, we additional lanes, including some turn lanes, a bridge replacement in this location, bike and pedestrian accommodations, sidewalk. This project is currently fully funded for design and right of way. And we're currently progressing that design. We're currently about 60% and also progressing our right of way acquisitions, which are needed for utility relocation and construction. Unfortunately, both of those at this time, utility relocation and construction, are not funded. But assuming we're able to identify that funding, we hope to start relocating utilities next summer, which would take about 2 years. There's about 5 different utilities, but that work would begin, and then the roadway work would follow up right after that. So again, we are excited about being able to keep this project progressing in these challenging times. And with the budget, the secretary and administrator last fall, when they were out on the CTP tour, were relaying how tough the budget was. The budget is very tough, and some tough decisions had to be made. And the administration's been very focused on continuing, maintenance and construction projects that are already out there. But this project has funding, and we're really happy to be able to keep it progressing. I guess with that, we can take any questions you might have. And again, I have the district engineer on here with us, and our director of highway development to help me. They know they are.
Yep. So Jason, I just kind of want to, we got a few things that came in. The first is, what are the stormwater plans for the area, including on Flatiron Road? Jason, you there?
Yeah, I'm still here.
Sorry, did you hear my question? Somebody had asked, what are the stormwater plans for the areas, including on Flatiron Road?
Good question. Ari, can you answer that one? The question is, what are the stormwater management plans?
Yeah, so we have, I guess that's a pretty vague question, but I'll try to be as clear as possible. So for Flatiron Road, I'm looking at the plan set right now, so unfortunately I can't share that with you. But the project does tie in not too far from the connection of Maryland 5 and Flatiron Road. So we will be providing some storm drains in the approach to Maryland 5. There is some proposed bioretention or stormwater management facilities very close to the Maryland 5 connection to Flatiron. But it's very difficult at this point to give any final decisions. We typically don't have final stormwater management design at this point in the project. But there is some proposed facilities and closed drain systems as it pertains to Flatiron in connection at Maryland 5. So about 150 feet to 200 feet off of Maryland 5, we have some additional storm drain work that's being proposed there.
Yep, appreciate it. So I think we're getting a whole bunch of questions here regarding the process and then what the overall plan is. So I just kind of want to back up here. The crux of the problem for this intersection actually isn't the intersection. It's the bridge that is probably 100, 200 meter or feet north of the actual intersection, just past Sheets. You don't even realize it, but there's a little creek there. And currently we have to redo that bridge so that it can support the additional weight of adding additional lanes so that we can increase the size of the intersection in and of itself. So if you, and I don't know if everybody can see my cursor here, but what will essentially happen is there will be the turn lanes here to go left onto 246 as you travel south on Route 5 will be extended. And additionally, you'll get a lane on each side all the way up past where the Great Mills Trading Post is at the moment. And so the thought process there is that now the people that come south on 246, they will be able to make the right onto 5, and the people who are going north on 5 already will be able to continue in their lane of traffic. So you are adding 2 additional lanes, one in each direction, but specifically for the afternoons, you're adding an additional lane all the way up past the intersection at Flatiron. Now, we did get a question on what was the approval process. Sorry, trying to slide this out. But what was the approval process followed for this project? And, you know, because I think one thing that many St. Mary's County residents look at and see, and the question I've had from the start, but I don't want to delay the project anymore because I do think we need to get this thing started, is why aren't the 2 lanes taken from not just where Great Mills Trading Post is, but up all the way to the light in Callaway. So that way you have 2 lanes continuing to go north past the light in Callaway where some people turn off traffic and go down 249 towards Piney Point.
I'm not sure I'm the best to answer that question, but I think, you know, it would be best probably to look at the scope of work that came out of planning. I know that with this project, the biggest area of emphasis was between 471 and 246, and not necessarily beyond those limits of work because of the interest in getting the traffic issues resolved between those 2 intersections. But off the top of my head, I don't recall the exact reason why the scope of work did not progress beyond those intersections.
Okay. I mean, if we could follow up on that and then I can send it out, that would be really helpful.
Absolutely.
Yeah,
A lot of people.
we can definitely do that. You know, there was a overall planning study for the whole corridor, and I don't have all the exact history of this particular corridor, but many times when you have a breakout project, they look at some logical termini that gives you a project that has independent utility. But we can definitely get you a fuller answer on that as a follow-up for sure.
Yep. And my 2 follow-up questions I'll ask on this. First, a general comment. Somebody had asked, will the stoplights at Great Mills be eliminated? The answer to that is no. Really, the increased efficiency or flow of traffic is through the additional lanes. And then, you know, you can adjust the timing of the lights based on the new traffic pattern after we take a look at that when the full intersection is implemented. That is typically how it works. And you can correct me if I'm wrong, Jason, but I believe that's how it works. Additionally, you know, there's a question regarding timeline for utility identification. You know, and I think what people down here kind of get frustrated about is like, when can we put a shovel in the ground? And we all realize that these projects take a while. Nobody is, you know, naive to that. But the reality is, you know, when I came into office just 2 years ago, this wasn't even a real priority or a thing. And I've just been completely obsessed with it. You know, and I'm sure I'm driving Mitch absolutely crazy every day, but the truth of the matter is, like, if you fix this, like, I will just go away, at least for a little bit. But, you know, when somebody, I think it was Jason, had briefed, you know, there's going to be utility identification. I'm sure SMECO is going to be involved in that. First, what is the typical timeline? What is the timeline anticipated for this specific project? And who at SMECO can I call to speed that timeline up? Because I'm happy to do it. And I understand we got to get money in the budget for it first. And that's on me too. I'll take full heat for that. But, you know, obviously this is going to happen in phases, but we're just trying to look for something realistic. Like, hey, we're going to break ground on, you know, this day. And I know we might not be able to give you, or you might not be able to give us a specific day, but we would like to know, like, you know, this is going to happen in somebody's lifetime.
Yeah, no, of course. And I mean, we have a project schedule. We call it a production schedule. It's a project schedule that you just don't have construction funding, but we do have a schedule for that. And we have some right-of-way acquisitions in here that those take some time, and the acquisitions are needed to be done ahead of time so that you have a place to move the utilities to. And,
Yep, so real quick, how long do we anticipate? I know some of them are going to take a little while. Some of, you know, one of them is Bubby Knott's facility. But how long, just give or take, do you think, you know, that will take?
Those acquisitions take about 2 years.
So 2 years before we can start the utility process, and then
No,
that.
so right, no. So we're hoping to start the utility relocation, you know, assuming we can get that funding. It'd be next summer, it'd be summer of 22, right? All right, Eric? Eric, you there?
Summer of 22 would start utility relocation.
Utility relocations, and there's about 5 different utilities, and that length of time. So I mean, that, you know, that's shovels in the ground, not necessarily for roadway work, but for the utility work that definitely needs to happen. And that's about 2 years of utility work. Then the roadway work would follow up behind that.
Okay. And I don't have any other questions. Appreciate you guys' time tonight coming out here and briefing on a realistic timeline, you know, for people. We just got one more that came in. Is there any plan for bikes in this plan overall?
Yeah, and there is, and I don't know if you can see. So on the visual there, the project visual at the bottom on the left, you can see the typical section there, and you can see the all the travel lanes, and then toward the outside you have bicycle lanes there, as well as the sidewalk. So yes, there is bike accommodations.
Yep.
And we are replacing that bridge, so that'll be a good thing as well, and allows us to get that typical section in there.
And not just the bike lanes, but it's continuous sidewalks on both directions too. So,
yeah.
All right. Well, I appreciate your guys' time. Thank you so much, Mitch. Thanks for putting this together. I'm sure we'll be texting each other soon enough.
Yeah, Delegate, thank you. And I'm glad this all worked out, and you know, you all take care and appreciate it.
Yep. Talk to you soon.
Yep. Have a good rest of your meeting, and stay safe. Thank you.
You too. With that, I want to turn our attention to COVID, which is no doubt we are in the middle of the pandemic. And this is certainly feels like the height. I know we've been at this for quite some time, but we are far from out of the dark, even though there is light at the end of the tunnel, so to speak. First, I just want to kind of touch nationally. Everybody knows there's about 21.5 million cases, and we're now have eclipsed the 360,000 death mark, which is somebody else's loved one, their grandparent or parent or kid. that aren't at the dinner table anymore. And that's tragic. And we should be taking every measure, every precaution that we can to make things safer for not just, our fellow Marylanders, but our family members. In Maryland, while we do have a high positivity rate at the moment, it is still low compared to the rest of the nation. We have almost 300,000 confirmed coronavirus cases, and we've had almost 6,000 fellow Marylanders pass because of the disease. And I can tell you, I am familiar with at least 4 individuals in the county that we have lost to the disease. And 44 of our fellow states, our fellow citizens have lost their lives in the last 24 hours. Additionally, current hospitalizations, which is an extremely important metric for making public policy and decisions, especially at the state level, is up over 1,800 right now. While it did come down over the last 24 hours, 28 hospitalizations, it's still extraordinarily high. In St. Mary's County, we've had almost 4,000 confirmed cases, and we've lost 84 people to this disease. And in the last 24 hours, we've seen an increase in over 100 cases here in the county. At the bottom there, and we will send out these slides, they are they are the sources, they are the sources that we go to each and every day to try to get our stats and have real conversations. The best one there, off to our own horn here, is St. Mary's County Health Department. Mina Brewster's team does a fantastic job updating that each and every day. And with that, I would like to welcome our next 2 panelists. First, Dr. Chen, who is an infectious disease physician and scientist at the University of Maryland Medical School, who specializes in clinical vaccinology. He studied at the Howard University College of Medicine and completed his residency at Hopkins. Currently, he serves as the chief of the Adult Clinical Studies section at the Center for Vaccine Development and Global Health, and is a member of the Maryland COVID-19 response team put together by Governor Hogan. He is certainly not just a leader here in the state, but globally on vaccinations. Turns out he's not even my favorite doctor here this evening, because we have our very own Dr. Mina Brewster, who we're super lucky to have working countless hours. I would venture to guess she is there at 8 a.m. when I call her, and she's there at 10 p.m. when I'm calling her, working tirelessly for our fellow residents here in St. Mary's County. And she's done a remarkable job, but it's not just her, it's her entire team that have put in those hours to making sure we are safer here. And with that, I'm going to turn it over to Dr. Chen, and I will let him go through his short presentation, and then we'll follow that up with Dr. Brewster. So Dr. Chen, if you want to take it away.
Absolutely. Well, thank you so much for this invitation, Delegate Crosby, for speaking to your constituency this evening. And it's really my honor to try to communicate the science of vaccines to the public. I realize that there are a lot of questions, so I'll try to go through kind of the process in general about COVID vaccination, kind of approval, what we know about them. But I certainly am prepared to answer a lot of questions from the audience as well. So let's go to the next slide. Advanced slide. There we go. All right, so let me just briefly talk about the licensure pathway. So, for all vaccines and therapeutics and drugs, they have to be registered to the FDA, and they have to have studies to prove that they can be licensed. And the process is pretty general, is what I'm describing here, but it has to have a phase 1, a series of phase 2, and a series of phase 3 studies typically. And the phase 1 study really concentrates on preliminarily the safety of that new vaccine or therapeutic. It's really only 100 people or so. Then if that becomes successful, then it goes to the phase 2 trial. And that's where you continue to look at safety, but then you start looking at the so-called what we say immune response. And that helps us to predict whether or not it's going to be protective. And that's basically getting blood samples and looking at antibodies. And that might be hundreds to maybe a couple thousand people by that stage. Then if that continues to be successful, then we expand it out to what we call a phase 3 study. And this is where we, for the first time, then start measuring the efficacy of that vaccine or therapeutic. And that's where we hopefully will see protection or a treatment effect with a therapeutic or with a vaccine, respectively. And that involves tens of thousands of people. And so, early on, the FDA actually published the guidance for the industry on what is going to be required for the licensure of COVID vaccines. So this was published very early on. I'm just summarizing it here, but some of the things that are highlighted are that they want to see that these vaccines are tested widely in the population, a generalizable population that includes all facets of the population. So basically, young adults, older adults, those that are perhaps immunocompromised or have other comorbid conditions like diabetes, obesity, hypertension, etc. We also want to make sure that it represents the communities of color, so that have really had a high burden of the disease and death and mortality. So again, these are the things that they want to see in the testing of these vaccines. The efficacy of the vaccine has to be demonstrated to show that it can actually prevent symptomatic lab-confirmed infection. And then if possible, within those studies, we want to also show not just symptomatic protection against symptomatic disease, but also against, say, hospitalization, death, or even respiratory failure and other kind of very severe forms of the illness. And the statistics-wise, this basically speaks to, we want to be sure that these studies are done large enough so that you can assure that you have at least 50% efficacy with what we call, and I'll use some biostatistics language now, the lower bound of the 95% confidence interval should be greater than 30%. Well, what that means is that basically the FDA is really trying to tell industry that you need to design these studies to be big enough and generalizable enough so that we can be assured that it will work in the general US population. So that's that slide. Let's go to the next slide. So these are just an overview of the many COVID vaccines. Some of them, if you'll see on the extreme right-hand side, are in red because they failed. So I want to show you that this process works, that we have 2 successful vaccines. Those are the Pfizer and the Moderna vaccine all the way at the extreme left-hand side. Those are the 2 mRNA-based vaccines. We've got some more vaccines that are coming down the pike. This is AstraZeneca, AZ, which is a viral vectored vaccine. J&J, that's Johnson & Johnson, also a viral vectored vaccine. Novavax has a vaccine. That's a homegrown vaccine. That's a Maryland-based company. And it's a nanoparticle with an adjuvant. That's the type of vaccine that it is. And then we've got 2 other vaccines that you probably didn't hear much about in the press, but because they were not successful and they stopped. And basically, I just bring that up because our process works. We have safety and efficacy features that are built into these studies. And if they don't succeed, they're stopped. And so you can see that they were halted respectively, one because of a poor immune response, which means that we predicted that it wouldn't have good efficacy before it went any further, we just stopped it. And the other one was because it elicited false HIV positive tests. Didn't cause HIV, basically it caused so that when you got immunized, the antibodies that you had cross-reacted with the HIV test. So again, that would be a problem with the eventual safety of giving these vaccines, in that it's not giving you HIV, but it basically will cause a false positive test in the future. We don't want that to happen. So again, we stopped that study. So again, I just wanted to describe to you that there are a number of candidates that are being evaluated. They only continue to go further if they're successful, and they are stopped if they are not successful. Next slide. All right. So what can we say when a vaccine is licensed? Well, we can only say so much, from the scientific point of view about the safety. We can talk about how much we saw about the common adverse effects. So that's where you see reports about the injection site reactions and systemic reactions, which is basically like a whole body aching or feverishness that people might have with the Moderna or the Pfizer vaccine. Again, some people have it, some people don't. Some people have it very mild, and then a handful of people have it where it's more severe and they feel like they want to call out for a day or two. But it really does only last for a day or two and it self-resolves. So it's very transient. There are maybe the ability for us to detect less common or rarer adverse effects. But again, I've described that the studies that we're doing are not in millions of people because we want to eventually get to the point where we can deploy it to the population. So we've evaluated in tens of thousands of people. So that means if the event is rare enough that it's in 1 per 10,000, we might be able to pick it up. But if it's rarer than that, we cannot detect extremely rare adverse effects if they're there, okay? We also can't tell you about the long-term adverse effects because we've only known about COVID for about 12 months now. So how are we supposed to know about the long-term side effects of a vaccine with scientific rigor? Now, we haven't seen, and there's no scientific reason for us to believe that there will be long-term side effects. So I can assure you of that, but I can't tell you with scientific definitive evidence because we haven't studied the vaccines that long. Okay, what can we say about the efficacy of these vaccines when we're evaluating them? We can say that they prevent symptomatic illness. We can tell you about whether or not they prevent medical complications, hospitalizations, or deaths. But they're not studies that really help us very well to tell us with good precision about whether or not they prevent asymptomatic disease, whether or not it provides long-term protection for a year, 2 years, 5 years, and whether or not there are slight differences. Say, for example, if the efficacy is different among young adults versus much older adults who have the highest burden of disease, whether it's different among different racial groups, so blacks versus whites versus Asians versus Hispanics. So again, I can't give you with precise knowledge about that information, but we are trying our best to collect that information and to communicate that to the public. Let's go to the next slide. So let me just briefly talk about, and this is what Dr. Brewster will probably hand off and talk about much more, but there is a lot of vaccine policy and implementation that we wrangle with dealing with these vaccines. So right now you're hearing about that the supplies are pretty limited. So when you have a limited supply of anything, like some of those hot Christmas gift items that again disappear off the shelves, they become hot items. So again, we have to prioritize these vaccines to the highest risk parts of the population. And that's why we've come up with the schema. We try to build in how we can think about using these vaccines with the maximum utility. How can we build in the maximum benefit? And part of that is why we are vaccinating healthcare workers, because we want to make sure that that workforce can continue to provide medical care during this pandemic. So that's why they're prioritized. We also thought very carefully about making sure that the allocation is equitable and that we have an ethical framework in which we justify our actions. So these are all dictated by national guidelines, but also you'll see that there are local jurisdictional guidelines as well. So there's flexibility so that the national guidelines will not try to conflict with the local guidelines at the state level or at the county health level. And of course, the logistics of all of these vaccines, again, to deploy them out to the public under those different conditions. Some vaccines have to be given with 2 doses separated by 3 weeks apart, some 4 weeks apart. So again, that is a logistical nightmare. Some of them have to be stored at ultra cold temperatures. Again, so all of these things have to be dealt with at the level of the boots on the ground who are delivering these vaccines. What I'm doing right now is trying to deliver a public health message so that you can understand the value of these vaccines. But we need to continue to do this because I think we need to dispel a lot of the questions, a lot of the misconceptions, misinformation, and even conflicting information that's out there. Because I think that there's a lot of fear, mistrust. There are a lot of reasons that, again, with all of this information that's out there, not all of it is good, it erodes our perception of the value of vaccination. And so again, my idea is we need to have all of this in place to try to maximize the benefits, minimize the harms of all of this, to communicate that to you, talk about equity and justice and fairness with the allocation of these vaccines, try to be transparent about how we develop these vaccines and deploy them, be evidence-based, and also make sure that it's feasible to implement at the level of the boots on the ground. Next slide. So this is, again, just kind of talking about, when we have low supplies, we have a strategy of trying to target this to the high priority populations, but then eventually we'll get to a point where we have lots of doses. We're going to surge in our capacity and use innovative broad-based delivery approaches, which means that local pharmacies, doctors' offices, maybe even dentists and other allied health workers will be deployed to be able to administer vaccines. And then even later on, we'll continue to have vaccines, but we will still need to continue to push out vaccines because a lot of people will not be immunized, either because of vaccine hesitancy. Hopefully we'll try to gain back the trust of the population and people will understand the real value of these vaccines, but we need to continue to try to encourage the population to be vaccinated. And so there's that pyramid, and I think Dr. Brewster will probably talk more about that, but that's basically the prioritization scheme. So the last slide is my ending slide, and I just wanted to give you a picture of myself. This was last week on Wednesday. I got vaccinated myself, and I'm holding up a sign to really declare the reasons why I think vaccination is important. It's important to protect your family. It's important for me to save more patients. It's important because we want to increase community immunity, and it's important because we want to eventually open up Maryland. So thank you so much.
Dr. Chen, thank you. And before we get to Dr. Brewster's slides, I think these questions, some of the questions I think directly are more applicable to your presentation. So I'll just ask them while we're in the flow of things. The first one, and maybe even I could take this one, is what is the time frame between vaccine doses for between dose 1 and dose 2? Generally, it's 3 weeks, and in some cases, some vaccines are 4 weeks, correct?
That's right. I think it was my third slide, if you want to call that up, but it's the Pfizer vaccine is 3 weeks apart. The Moderna vaccine is 4 weeks apart. Now we're a little bit forgiving, so that here you can say I put it in days, 21 days and 28 days. So that's a logistics thing that will be handled at the level of the clinic, and hopefully when they give you your appointment for your next visit, they will have calculated out the appropriate interval between those 2 doses. Now, what happens if you delay those doses? It's no harm, but of course we would rather deliver those doses as quickly as possible within that interval that's suggested, just so that we can get more of the population to complete the 2 doses. You might have heard in the popular press how the UK folks are planning on delaying that second dose out to even 12 weeks. So again, that's a tactic, a strategy, so that they can try to give more of the population at least 1 dose. But again, my strategy is to try to get all Marylanders complete their 2 doses. So again, it's just a different strategy for a different country.
Right,
Okay?
and I think
FDA is not endorsing delaying vaccinations.
Yeah, I think one of the other challenges too in America right now, at least from what I've read, is that we've received 17 million doses have gone out. And the problem isn't, the amount of doses that we have on hand. It's been the administering of doses.
Yeah, that's right. It's that logistics nightmare, which I think, again, is hard to appreciate unless you run a vaccine clinic. But, we have to have the IT infrastructure to even just have the centralized database to enter this, because the state has a mandate to report back to the national level. And so each county has to report to the state has to report to the county. My medical system, University of Maryland Medical System, is composed of 13 different hospitals and urgent care centers that are associated with those hospitals and our private clinics. So we have 28,000 member staff and employee that we have to also independently vaccinate as well. And we have to report out back to the state as well. So that's an IT kind of nightmare where all of these different entities have to report back out. That's just one part of the logistics of deploying these vaccines, but you still have to have trained people that are able to administer these vaccines. You have to have safety built in, so that PPE, so that distance, so that the appointments are not piling up on top of each other. All of this stuff has to be maintained when you have a vaccine clinic. And again, Dr. Brewster, I don't want to take her thunder away, but that's kind of the things that she's dealing with as she's standing up these clinics.
So the next question we have: how do trials of vaccines consider pregnant women or nursing women? Is that a concern?
Yeah, so the trials for pregnant women are being stood up right now, so they're being done. You know, the initial studies, we try to exclude pregnant women, again, because we recognize that it's a vulnerable population of not just one person, but two people. So again, we try to, again, when we perform these studies initially, make sure that we are ensuring the safety and welfare of our study participants, as well as, you know, measuring the outcomes of interest for the studies, you know, the goals. So it's only after we've done the initial studies that we start expanding it out to pregnant women. And now you're also hearing about children's studies as well. So again, pediatric studies have not been performed, but they are being arranged right now so that we'll have those data to be able to deploy them to pregnant women and to children. So right now, pregnant women are able to get vaccinated. It's just that we don't have the data on them, but there's no reason that these vaccines will have any more harm to the fetus or breastfeeding mother.
Yep. Next one is 50% efficacy a standard for other vaccines? And then what is the minimum efficacy for like a flu or shingles?
Yeah. So for flu vaccine, I think it's about 50% is what we're seeing. In some years, it's 40%, and they're still licensed. So that 50% is actually, you know, just a bar to say this is what we need to be successful to actually have public health value. What we have been pleasantly surprised by is that the Moderna and the Pfizer had 95% efficacy, really just knocked it out of the park. So we are super happy about those two vaccines. The AstraZeneca has a little bit conflicting information from two different studies. One says 70% efficacy, which is still great. And the other one is 90% efficacy, which is terrific. So again, I'll take that. That's still a valuable vaccine. Now, when you compare it to the efficacy of 90% and 95%, you know, again, it's hard to compare when you've got a terrific vaccine like that. But again, that doesn't mean that a third vaccine will not be helpful. Because again, we need to deploy these vaccines to the world. We need to make sure that these vaccines are accessible to low and middle income countries, which are also highly afflicted. Again, if we only are able to stabilize the pandemic in industrialized countries, we'll continue to see outbreaks coming from other parts of the world that'll come back in and be introduced to our population. So again, it doesn't help us if we only think about the US. We have to think globally about vaccination. You're on mute.
Yep, I couldn't agree more. Next question, will a vaccine work or be available to individuals who already had COVID? My understanding is they're just going to fall under the same pyramid, correct?
They're going to fall under the same pyramid of their prioritization. People who had recent confirmed COVID are instructed or recommended that they can wait for 90 days before they get vaccinated, because there is short-term kind of protection with the natural infection if you recover from it. You know, not everyone, you know, fully recovers from it. Obviously, there's the long haulers, people who lose their taste and smell and all this other stuff with getting natural infection. So I don't advise people trying to get natural infection. But if you do happen to get a natural infection and you recover from it, we're advising that you wait for 90 days.
Was there anything in the trials that confirmed or maybe certain blood types were, you know, experienced less harsh cases of COVID? I've heard that rumor going around.
Yeah. We saw one study. This is a good question. We saw one study that looked like that there was some evidence that people who were blood type O might actually have less severe disease. You know, that's a phenomenon that we see, you know, blood type and severity of disease with other diseases. So I work with cholera, which is a diarrheal disease in developing countries. And we know that people who are blood type O have very severe cholera compared to people who are not blood type O, so that are, you know, A or B. So again, sometimes blood type will dictate the severity of disease. I don't know that the evidence is very clear for COVID. That was just one study that showed that. We haven't seen it replicated anywhere else. So I'm not sure if that's true or not.
I hope it's false because I got A positive blood.
Okay.
And then the last question we have here is that somebody had heard rumors that the vaccine might alter the DNA of someone's DNA. And I just kind of want you to touch on that. And I think this is one where we can try to really build public confidence on some of the questions like this.
That's right. Yeah, that's one of those misinformation out there, and there's a lot of it. So I don't blame the person for asking because it is a common question. So no, the mRNA-based vaccines that are out right now do not integrate into the DNA, do not change the DNA in any way. All they do is that they come into the body and they actually degrade relatively quickly. They present themselves to the immune response, the immune cells, and then they basically see the spike protein from that mRNA. And that spike protein is the part of the coronavirus that we're most interested in protecting against. That helps us to build protection. So it hands off to the immune system, degrades very rapidly, and is eliminated very, very quickly. So it doesn't stay in the body for a long time, does not integrate in the body, does not change your DNA.
Awesome. I also noticed, real quick, if we go back to the previous slide, the Johnson & Johnson one is one dose. Is there any reason, like I have read many articles that we kind of just stumbled upon having 2 doses. It was like, oh, we tried the booster shot and it actually ended up being better. I don't know if that's true.
That's right.
That one dose and the rest are 2.
Yeah, I think, what I heard from Johnson & Johnson, and again, they haven't published all of their data, and the phase 3 trial you can see started in November. So we might be hearing very soon in the next week or 2 about this vaccine, but it is being developed as a single dose vaccine. Now, if we gave 2 doses of it, would it make it even better? And it's possible that it might make it better. But you know what? From the logistics point of view, to give 1 dose to a population is far better than having to give 2 sequential doses. So I applaud them for kind of trying to develop it as a single dose vaccination. Now, I hope that we'll see that the data is just as successful as these other vaccines. Of course, we want to see that the efficacy is 50% or much, much greater. I would love for it to be in that 70 to 90 some percent efficacy. But again, let's wait for the data. But yes, that's the plan, is that they're developing it as a 1 dose. I know their fallback plan is if it doesn't look like the data looks good for 1 dose, that they're going to fall back on a 2-dose regimen, which again puts it in line with all of these other vaccines. So again, they're trying to separate themselves out and try to be, again, logistically reasonable by being a single dose vaccination. So I, again, applaud them for trying to do that. Let's see if it's successful.
Yeah, it was a rough year for Johnson & Johnson. I mean, obviously they couldn't get their vaccine out, and the New York Jets are horrendous football. I know that they own them. Last one, and this is, this is something that I've kind of been thinking about too. And frankly, I don't think there's data, but you can touch on this. Is, are you going to need to get the vaccine every year like the flu shot, or is it going to be a one and done?
Yeah, that's a good question too. Very commonly asked as well. And the simple answer is I don't know, because we don't know how long these vaccines last, and we don't know how persistent these viruses will be. I think my predilection is that we're probably going to see them come back every winter, but it won't be like right now, the pandemic. It'll be more like one of the common cold viruses that we encounter every year. And so we might have to do annual vaccination if the vaccine only lasts for 1 year at a time. If the vaccine ends up lasting 2 years, 3 years, 5 years, then maybe we'll only need to have those boosters every, so often, every 5 years or so. So again, I don't have the data to know yet, but stay tuned. That's a great question. We just don't have the data to drive that answer yet.
Dr. Chan, we really appreciate you coming. You were phenomenal. The bow tie really made the present. Did all the heavy lifting for us. So thank you.
Absolutely. It's a pleasure to serve the public. And Delegate Crosby, thank you so much for the invitation to be here.
Yep, no sweat. All right. And with that, nothing against Dr. Chen, but we're going to turn it over to my favorite doctor, Mina Brewster, from our county's health department. It's so good to have her on here this evening. I'm going to pull up her slideshow. 1 second.
Thank you. Dr. Chen, that was awesome.
Pull this up. You got it? There we go. How you doing?
Good, good. Hanging in there. How are you? Thank you for having me on.
Thank you so much. I appreciate all the time you're putting in. I like the outfit tonight, straight gangster. That's how you are every day.
Doing vaccines every day, so
Yeah.
in the mode.
All right, well, I'll turn it over to you. And I think, on behalf of everybody in our community, I just want to say thank you. I know it's
Thank you.
crazy times, but your leadership has been incredible. And it's not just you. I recognize that. It's your entire team.
Yeah, they're awesome.
Department. So, I want to thank Jenna for putting this together, and getting everything squared away for us. But it's the people day in and day out too in your organization that are doing wonderful things here for St. Mary's County. So I'll turn it over to you.
Thank you. Thank you, Delegate Crosby, and thanks everyone who's tuning in. Dr. Chen, your presentation was great and really appreciate all the scientific data you summarized for our community here in St. Mary's. So I'm going to talk a little bit about COVID vaccine as a local rollout. Some of you may have already seen, if you tune in to the Board of Health meetings, I gave a recent update just a couple of days ago. So if you saw that, I've updated some of the information since then because we've had some additional guidance from the state so that I incorporated in the slides here. All right, if you can go to the next one. Great. So hopefully, for those of you living in St. Mary's County, you're already in the know about our local data dashboard. We put a lot of effort into it. We have a whole team of individuals who are working on a variety of data sources and keeping track of a variety of data sources, some of which we were able to publish and summarize for our whole community. These are just a sampling of some of the data that we have available on our website. The address is there, right there in the bottom corner. But what I really want to say is that, and to echo what Delegate Crosby said earlier, we are in a surge. We are currently entering a very steep post-holiday surge when we never really recovered at all from the post-Thanksgiving surge. So it's kind of a surge getting superimposed on a surge that didn't quite come down from December. So it's a grim picture right now. We're very concerned about what's going to happen in the next few weeks. And that's why it's so important to continue practicing your social distancing, avoid gatherings with non-household members, keep mindful of any symptoms that appear, know where to get tested. We run 2 daily testing sites through the health department that are available to our residents. And certainly, just do what you can to prevent infection with COVID-19, washing hands and wearing your face covering everywhere, and especially when you're amongst other people who live outside your household. So it's a grim picture. I know we've been at this for so many months. Everybody's exhausted. Totally understand that, and we all wish this would go away. We're never going to forget 2020 because of this pandemic, but we've still got a little whiles to go. If you go to the next slide, please. But I will say, despite all the seriousness of what's going on and the grimness of the current surge, there is this light emerging in the darkness that we're currently in, and that has everything to do with the potential around offering our residents COVID-19 vaccine. This is also a data point that we publish on our website daily. We have now vaccinated over 1.5% of our population. It doesn't sound like a lot, but we just started a few weeks ago. And like Dr. Chen was mentioning, there's quite a bit of logistics involved in mobilizing vaccine. And I'll talk in a little bit more about the different partners who are receiving vaccine here locally and how we're going about getting it out into the arms of our residents. Just so you know, the number that we put on our local website involves data delays. So the number there that you see on your screen is about a couple days delayed from the actual number. So the actual number of people who've in St. Mary's County that have received vaccine in their arms is higher than this, significantly higher than this. But it takes a day or 2 or 3 for the data to catch up. And also, we are right now vaccinating primarily people by their occupation because they are in a high risk occupation. And so here in St. Mary's County, as I'll talk about in a moment, we're vaccinating first responders and healthcare workers. It doesn't matter if you are a resident of this county, as long as you work in this county as a healthcare worker or first responder, then we will offer you vaccine. And so this number here on our daily website only reflects St. Mary's County residents. So if there's somebody who lives in Calvert or somebody who lives in Charles County that comes down to St. Mary's to be a firefighter or comes down to St. Mary's to work at the hospital, they will not be reflected in this number, but we are delivering vaccine into their arms. So please keep that in mind, that again, this number here that we publish every day on our website is likely an underestimate of the actual numbers of vaccines that we've given out in the past few weeks. Also, so you're aware, the local number does include the vaccines that are being administered by the base. The numbers that are published on the state website for St. Mary's County do not include those numbers. We get those numbers directly from the base, but they don't report into the system that Maryland reflects on the state website. If you go to the next slide. So Dr. Chen had already showed this illustration, but Tuesday night after I gave the Board of Health presentation Tuesday morning, the state updated and made public its updated vaccine priority list, the categories. You know, you may have heard the words phase 1A. That's the phase that we're currently in, where we're vaccinating healthcare workers and various types of first responders. And we're also really focused on the very vulnerable populations within our long-term care facilities or nursing homes. But then we have these other phases that we'll be moving into as we are allowed. Unfortunately, we don't have local flexibility to move forward through these categories. The state has told the local jurisdictions that we don't have that authority. And so, I do think that's going to have a disparate impact on the smaller communities here in the state. We're hoping to change that. But for right now, we're not allowed to progress forward into the next category, even if we are ready to do so locally. The next category of phase 1B will be adults 75 years and older, and will address education and childcare providers, and then those who are in this continuity of government type of role. So kind of essential positions or roles within government that keep community running. And then phase 1C will be the next age group as listed here on the slide, and a variety of other essential workers that are needed to keep community functioning, very kind of critical services for basic needs in a community, farming, for food, manufacturing, postal service, those types of services. And then phase 2 and phase 3 keep expanding who is eligible to receive vaccine as more and more vaccine supply becomes available across the world. Next slide, please. So like I mentioned, we are still in phase 1A in the state of Maryland and here, of course, locally. There are 4 entities primarily vaccine in St. Mary's County that are administering vaccines in St. Mary's County. So MedStar St. Mary's Hospital was the first entity in the county to receive vaccine, and their mission is primarily to vaccinate MedStar Hospital employees or staff, and also they've more recently begun expanding into vaccinating MedStar outpatient staff and so forth. So they have maintained a very steady pace of vaccination, and like I said, they were the first ones in the county to roll out vaccine, and that was really just a few weeks ago. The National Pharmacy Partnership is something that's been charged at the, like I said, at the national level. They've made arrangements with different pharmacies, including the big ones of CVS and Walgreens. And so those pharmacy partnerships have been activated by the state of Maryland to go out to all the nursing homes throughout the state and vaccinate the staff as well as the residents who live in those nursing homes. So here in St. Mary's County, we have 3 long-term care facilities: Charlotte Hall Veterans Home, and they will be receiving their first doses on January 13th, Chesapeake Shores Nursing Home, and St. Mary's Nursing Center. And the last 2 have already received their first dose of vaccine here in St. Mary's County. The next are the local health departments throughout the state. And here are St. Mary's County Health Department. And Delegate Crosby, appreciate your words earlier about the quality of our team and just the hard work that's been happening through our team. We do have a really phenomenally committed and compassionate people who live here or live in the region and who care about their neighbors. And we've been working nonstop, 7 days a week since the pandemic first started. And there's a lot of thought and dedication that goes on across the whole team. So I really just want to recognize them. I mean, it's a whole a wonderful team that's really cares about our community here. But so us as a health department, we are also incredibly fortunate to have these amazing partnerships in St. Mary's County. I mean, we really are lucky here in St. Mary's County to just have such great working dynamics. It's like that neighbors helping their neighbors kind of mentality. You see it at the organizational level too. And when a pandemic hits, that mentality really makes a huge difference. And so we've actually come together with several key partners in our community. There's several of them, but I'd say the main ones are the local Department of Emergency Services, the local Sheriff's Office, the Department of Public Works, as well as our local EMS departments, and especially our paramedics who've been assisting us with vaccinations. We've also gotten our school nurses on board to assist with vaccinations as well. So there's definitely some partnership there with the public school system. So all of us are working together to try to get these other categories that I've listed here vaccinated. And I'll describe in a moment a little bit more details there. We are already as well, there's a group of us from the health department that will be going around soon to address some of these congregate living facilities, like the assisted living facilities and DDA group homes, et cetera, to get them vaccinated as well. So the health department and then Department of Defense, so the Naval Air Base Pax River is already vaccinating several of its employees as well. Next slide, please. So our vaccine administration involves drive-through mass vaccine clinics. It involves going out into the community settings, especially those congregate living facilities where it's hard for people to mobilize out of those congregate living settings and to vaccinate. And then eventually, once there's enough supply, we'll be offering vaccine at our daily testing sites as well. But right now, we are trying to be the most efficient as we can and getting those vaccine doses we receive into the arms of our residents. And so we've organized these drive-through mass vaccine clinics, and up there is a picture of one of them. We received, the health department, SMCHD, received its first dose the week of the 21st. And that same afternoon, after we were able to thaw out the vaccine that we received, we began administering it. And the first week we received a very, very small shipment, and we used most of those with the people who are going to be helping us with vaccine administration. So all the people who are vaccinators, we also vaccinated our testers at the COVID testing sites and so forth. And so we ran through that supply fairly quickly. We were waiting. Every week we get a new shipment from the state. And the next shipment was also very small. It was only 900 doses. And so the week of the 28th, we mobilized those mass vaccine clinics for the first time with our partners. And we administered over 900 doses, the 900 that we received, and then some that were remaining from that first batch of 100 doses, so we've gotten them into the arms very efficiently and very quickly. Really, we just needed more vaccine at that point. This week, with our new shipment of vaccine supplies, we're also operating mass vaccine clinics. And like I mentioned, we're going into these high-risk congregate settings as well to provide vaccination. Our challenge now is that we are ready locally for phase 1B. We don't want to be sitting on vaccine supply, but that will happen if we're not given the authority to move forward into phase 1B and have to wait for the whole state to be ready to move into phase 1B. So we really, like I said, we need to be efficient. We have a mechanism, we have the partnerships, we have the volunteers, we have everybody working phenomenally well together here locally. We just need the permission from the state to be able to move forward so we can continue vaccinating the population that needs it here in St. Mary's. Next slide, please. These are just some pictures. I thought I'd like to highlight that. Some of you may have already seen these through our social media posts. But again, I mean, we've got some incredible partners in our community. We've got some incredible people serving the front lines of this pandemic and the front lines of our community all the time. healthcare workers, first responders, law enforcement, really, just some absolutely amazing people here. And we want to get them protected. We want to get our whole community protected. And so again, our focus is to be as efficient as possible and to be, we're ready to work 7 days a week and holidays. I mean, we do that anyways, to get these vaccines into the arms of our residents.
Mina, thank you so much. And I kind of want to touch, well, first off, let me commend you. I mean, the team has been absolutely amazing. Everybody that's volunteering at this vaccine distribution site should be commended. And we're extremely lucky and thankful. The governor had even recognized us as one of 4 counties that are at the top of the pyramid for processing and getting vaccines in people's arms. It's us, Calvert, Howard, and Montgomery counties.
Caroline.
Challenge of that, and Dr. Brewster had touched on this, is that the way the governor's plan has been set up is that the whole state has to get phase 1A done before anybody can move into phase 1B. And St. Mary's County has done such a good job that we've exceeded the timeline and we are ready to move into phase 1B, but we cannot. We're well aware of that here within the delegation. We're working with Senator Bailey and the governor's office to try to get more local control and local authority over the distribution process. And just so that everybody is aware, when you go, you have to show either your license so that you're a resident or proof that you work here. So there is the ability for us to screen individuals to make sure that they're actual St. Mary's County residents. So that way, if we're ahead, and let's say we were to move to phase 1B, then somebody from Charles County couldn't drive down the road here and get one of our vaccines that is supposed to go into the arm of a St. Mary's County resident. So we're working with the governor's office to try to bring that policy hiccup to his attention. And hopefully Dr. Brewster will be granted a little bit more authority and leeway to move into the next phase. That way we can get more St. Mary's County residents vaccinated. Okay, so I got a few of them here. And I'm just going to run through some of them. When the vaccine becomes more available, will there be more centers set up, or will we have to visit our primary care physician?
Yeah, great question. So we actually, like I said, we have great partners that we're working with here locally, and we've been spending a lot of time on planning. We even set up a separate incident command system specifically for mass vaccine. We have one for COVID, but we set up a new one for mass vaccine. We have 4 sites in the county that are pre-staged to operate drive-through mass vaccine clinics. We're only operating 1 clinic right now because we don't have enough vaccine supply to warrant setting up multiple ones at the same time. And it takes a lot of logistics and operations and manpower really to make these sites work. And dozens of individuals and a lot of people pulled from other roles and that other work now being neglected because they're focused on this and a lot of management of that process. And so one site is pretty intensive. And so we're operating 1 site right now, but we are able to operate 4 if we need to and also if we get the staffing support to make those happen once we have enough supply. I do envision that right now, the most efficient mechanism we have here locally is what I described earlier. The hospital is doing vaccines every day. Our local health department and partner mass vaccine drive-through mechanism is incredibly efficient. And if we keep the majority of the vaccine supply coming in through that mechanism, we will be the most efficient and will have the least wastage of doses. Because when you open up a vial, you only have so much time to use the doses that come in that vial. And if you splinter out too many places receiving vials and they don't have enough people scheduled for that time slot, then you may end up in a situation where you run into 1 or 2 doses here and there being wasted, and collectively that ends up, those are just missed arms opportunities to get doses. So right now, we are doing this. I do anticipate at some point that our primary care offices, especially as we get closer to phase 2, but our primary care offices will also likely start receiving vaccine if they've registered and expressed interest in storing that vaccine and administering that vaccine.
Another question we got is, do we know the comorbidity rates in phase 2? And then the CDC has 2 categories on its website. One is at increased risk, and the other is might be at increased risk. Will it be one, both, or a mix? I'll be the first one to tell you, I don't have a clue what this question is.
Yeah, that's a great question. And that's why I was saying with phase 2, it might be, it's going to be a little bit more of a challenge. And that's really where we're going to be relying upon primary care offices that are offering vaccine, because they'll know their patients best. And it'll be easier for them to verify who is actually at risk or at increased risk and would be a good candidate for vaccine at that point. So there is a set list of some conditions that we think increase somebody's risk for, severe COVID infection in particular. And so those are the ones that we're going to be looking at. But we'll have to see as we go through this process. We're going to have to look at what kind of vaccine supply is available and who's remaining at the times that we get to that point of being more population based. So if you do the whole thing population based, we can give estimates, and we have statistics, and our data team has brought together all those statistics for what percentage of our population likely has diabetes type 2, or what percentage of our population has underlying heart disease. But because we're going through a lot of occupational groups, we're also addressing people who have some of these conditions, so that by the time we get to that category of people who have comorbid conditions, we may have already addressed a good number of them by virtue of their occupation.
So the next question we have, and this is probably better phrased in saying, if you qualify for 1B, where do you get the vaccine? And really the question, I think, is when do you begin to open up those other drive-through clinics? What would trigger that opening?
Yeah. So when we do everything, we communicate out to the public. In fact, Jenna Guzman, she's our directing all of our COVID-19 communications and is doing a phenomenal job on that. So we put out a variety of information through our social media, Facebook account, Twitter, and also on our website, smchd.org, and then also by press releases. So anytime we're going to move into the next phase, we will prepare our community with a press release that gets, of course, shared by our local media resources. So if people are interested in following along, I would strongly recommend every press release we put out or every announcement about vaccine we put out will get shared out on our social media accounts as well. So if you tune into social media, tune into our page. And if you, don't necessarily follow newspapers, you can sign up for alerts on our website. So it'll send you an email anytime we put out a press release. So you can stay tuned to that. What we're doing is we're using surveys to collect information about occupational groups so that each occupational practice. So for example, healthcare providers, what we've done already for the past couple of weeks, we've been repeatedly sending out surveys to we have a local health alert network. And so we send it out to that local health alert network, as well as we released it by press release and social media. And so people complete the survey, we get an email address of their point of contact for their organization. We send them the invites for the closed clinics. They're called closed vaccine clinics. So we don't have random people registering in that really aren't eligible to be there, and then taking up those spots away from our healthcare providers and first responders. So they receive the invitation, they have to register in advance, and then they can show up at the vaccine site. So we'll do the same when we get to phase 1B. Because phase 1B involves a portion of our population, that 75 plus age group, we'll likely announce that by press release so that anybody 75 and older can register into the vaccine clinic. Right now, because we want to maintain efficiency and because we don't really have the vaccine supply coming to us that would warrant operating more than one vaccine clinic at a time, we will likely maintain our main site where things are all set up. It's a very efficient process. It's very easy for people to use, and it's a centrally located in the county vaccine clinic. However, we are really interested, and we have plans in place to open up the mass vaccine site that we are going to have located at Great Mills High School, because we also know that's the most densely populated area of our county, and it would allow for people to access vaccine who may not have their own personal vehicles. So we do recognize that. We're going to wait on that until we get to that phase where we can start opening it up to general population groups versus more occupational focus groups.
I mean, a question I have, this will be the last one really, is can you be contagious after you get the vaccine? Like if I get the vaccine, then I come in contact with somebody else who had it, and I don't want to say they give it to me, but maybe they give it to me and I fight it off real quick. Can I still give COVID to my fellow neighbor?
Right. And that's, so Dr. Chen was talking about this a little earlier, how the major outcomes that have thus far in the data been demonstrated are that these two mRNA vaccines that we're using, the Moderna vaccine and the Pfizer vaccine, they decrease the likelihood of severe COVID infection. They decrease the likelihood of even symptomatic COVID infection. But what we don't have an answer to yet, a definitive answer to yet, is how well do they decrease the likelihood of asymptomatic infection. So for right now, based on our understanding of this infection and these vaccines, we do think that people can still become infected, but they're more likely to remain asymptomatic. So they're not the ones that are going to have these long-term health problems most likely, or end up in a hospital, or feel really sick that they have to, they're dealing with, shortness of breath and that kind of stuff. But that also means that they may still be able to transmit infection to other people's, just maybe silently because they're not symptomatic. And so that's why even with having vaccine on board in your body, it's still really important to wear your face covering. It's still really important to maintain social distancing and to avoid gatherings with other people, especially vulnerable people, or individuals who might be more vulnerable to more severe disease. So I think, yes, we hope and we think that just by decreasing the severe disease and by decreasing symptomatic infection, that these vaccines, even if they still allow for asymptomatic kind of silent transmission of infection, that these vaccines will still decrease what we call the attack rate of a virus in our community. And that leads to less and less and less community spread of this virus. So we can start returning operations back to, where they really need to be for other parts of our community.
Thank you so much. I think the last question is actually for me, and it is, I got a text earlier and I got a few other people that emailed me if I plan to get the vaccine, and the answer is yes. I actually signed up to be a lab rat and a guinea pig. I don't know what the medical terminology is, but
Vaccine champion.
well, no. So I'm signed up to be a vaccine champion, but I think I actually volunteered to be in like a clinical trial. And I guess they determined I had weak genes. I don't know what the medical term for that is, but they denied me. But I am signed up to be a vaccine champion. I am going to get it. As many of you know, I was in the Army, so I don't even know half the vaccines that I have. I mean, you could have pretty much put motor oil in me. And I remember getting out of the Army. They hand you your medical file. I don't even know why. It should be digital, but whatever. They hand it to me and it's like a Bible. And I just remember asking the doctor, like, what is this? And he was like, that's all your vaccinations. Get out of here. And I was like, wow, okay. So I'm going to get the vaccine. I think everybody should get the vaccine, and or at least as many people as possible, barring some sort of significant medical issue and without a recommendation of a doctor. But I think it's the smart thing to do to protect your family and your fellow community members. But with that, Dr. Brewster, I know it's super late. You've probably been up since 5 a.m. working your tail off, and we really appreciate everything you're doing here in St. Mary's County. So thank you so much for joining us.
Absolutely. Thank you. And appreciate all of you and appreciate you, Delegate. Thank you.
Yep. Okay. So we got a little bit more. I'll kind of go through it pretty quick. But as we head into session, the biggest questions have certainly surrounded the state budget, and rightfully so. It's it's a $50 billion budget, and it drives most of the policy that we have here in the state of Maryland, and it really determines what we can do going forward. So every year, and it's been this way since I think the 80s, there's been a spending affordability board, and they answer questions like new debt, or can we take on new debt, or do we find funds that you care about, you the citizen care about, for certain projects or initiatives. And out of that, they came up that we're going to have a $778 million surplus. Not deficit, surplus. So we are going to be almost $800 million in the green this year, largely due to the federal government passing the CARES Act. But originally, if you remember, when people were trying to slash the budget left and right, there was a projected $2.8 billion revenue shortfall. Well, I mean, there have been a couple things that contributed to Maryland doing really well. One, like I said, there's the CARE Act, but two, we are heavily reliant on the federal government. And so, places like Pax River, while we may shut down the base, there are a lot of people that can still participate in the economy and work remotely because their jobs allow for that flexibility. Not everybody, and certainly I recognize that there are many people out there hurting, but from an overall budget standpoint, Maryland is actually in a good position this year. There will be a structural deficit of $650 million in 2021 and $817 million in 2022. However, that does not factor in another stimulus bill passing. And additionally, it also doesn't factor in us tapping into the rainy day fund. So, which was the first recommendation of the Spending Affordability Board. The rainy day fund, just think of it like the state's savings account. Each and every year we take money out of the budget and set it aside in case it rains. And certainly, it is raining right now. And we should be able to use those funds to cover any kind of structural deficit going forward. The other big recommendation that the Spending Affordability Board made is that they are going to cap the structural deficit at $700 million. So right now it's projected at $650 million. We will use, or they have recommended we use the rainy day fund up to $700 million. And then anything over that, then we'll look at more drastic measures. Additionally, if we are to receive any more federal funds, if Congress were to pass a bill, then all of those funds, the priority will be one-time expenses. So the best way I would think about that is broadband infrastructure. So we would invest in broadband, which would be a one-time shot where we prioritize those types of projects with those funds. They're not really things that we need to worry about in the future. I think that is it for this slide. Okay, so these are the bills that we are going to put forward this year. We have currently 12 bills that are going to go forward. The first is permanent daylight savings. This is, just a bill that I truly believe in the benefits of it. But, it's kind of funny that this is probably our most popular bill year in and year out. And we have gotten numerous questions on it. But the goal is to set up a compact between us and other states. So when Maryland passes this bill, it wouldn't go into effect until all these other states along the Eastern Seaboard pass the bill as well. But we would jump forward in April and we would just stay on that time. And the predominant reason really is health. car accidents, heart attacks, strokes, they're all up the day after we move the clocks one way or the other. The data is pretty amazing. And then just another tale that, I kind of want to dismiss any rumors is that this was tied to agriculture. It actually wasn't. It's tied to energy efficiency, and we're not seeing the same energy efficiency gains that people think are important. So it's a good way, or it's a good policy. And I think that maybe not this year, but when things get back to normal, the day after, or the first Monday after daylight savings and the clocks jump forward, you can write to me and say, yeah, this needs to go because I can't get my kids out of bed and get them off to school. I'll highlight the next two bills, and actually I'll highlight a couple more on this slide. So the first one, currently it's going to require county commissioners to win the plurality of their vote in their respective districts. So if you think about it, right now in many counties, what people do, and it's not what jurisdictions do, and it's not just St. Mary's County, and it's not just one party, is we have the county commissioner form of governance. And you have to live in District 1, District 2, District 3, District 4, but the county as a whole gets to vote on that individual. In my mind, and in my opinion, that's undemocratic. You should vote for the commissioner that lives in your district and not have your vote diluted by another area of the county that maybe doesn't necessarily know as much as your end of the county. And I would say that a commissioner from Mechanicsville, doesn't know nearly as much about Lexington Park, and a commissioner from Lexington Park doesn't know nearly as much as Mechanicsville. And this is a way to put direct representation of your area into play. And what I would say is, for opponents of this is, this is how it's done at the state level, and it's done at the federal level. I run in District 29B. Only 29B residents can vote for me. My vote isn't diluted throughout the rest of the state. And I can assure you that if we went to a form of like that across the state of Maryland, there would be another group not so happy because their vote would be diluted by the 95 corridor. So, I think that this, in my opinion, is a more representative democracy of you, the citizens. And you should be represented by the person that lives in your district, and you should pick them. I believe that. The second, which has been an ongoing battle, is to get the second early voting center here in St. Mary's County. Currently, under the current law, you need 100,000 registered voters to qualify for a second early voting center. St. Mary's County has 73,000. But yet the only early voting center is stuck, almost 20 minutes away from our drive down here. If you were to go from like Gate 3 up to Hollywood, and it's even exacerbated, during times of traffic. So what this bill would do is say, okay, if you have over 70,000 registered voters, then you have to have a second early voting center in your county. And this would only impact 2 counties in the entire state. Additionally, there are places like Garrett County that have like 20,000 registered voters, and they have 2. So to me, we should be giving people more access to cast their ballots, plain and simple. And I know that there's been a lot of hoopla surrounding whether it should be at Great Mills High School or this place or that place. There's nothing wrong with Bay District Volunteer Fire Department. And they could plan for it each and every, primary and general, and just put it on the calendar, no different than Hollywood. That way, people from Lexington Park, people from Ridge, and people from St. George's Island don't have nearly as far to go. The last one I kind of want to touch on is the final bullet here, which is establish the full faith and credit of military spousal licensure for health professions in the state of Maryland. And, that sounds great, but what is it? And and I experienced this in my time in the military when I would interact with so many of my friends' spouses, is if someone gets assigned from China Lake, California, and their spouse is a teacher, or well, no, and not in this instance, they're a nurse. If they get reassigned to Pax River and then become a member of our community, that spouse comes with them, and then he or she cannot participate in the economy or become a nurse at St. Mary's County Hospital because the license doesn't transfer. So all this bill is going to say is that if you can prove your spouse is an active duty service member, then if you have a license in a different state, we are going to honor that license temporarily until either he or she PCS is out and you leave, or they transition off of active duty. Then you would have to get a full-blown Maryland license. So that is the goal. I think it is good for our community. I think it is good for our service members. And I think that nationwide, both red and blue states are really realizing the value in this and the immense talent that our military spouses possess and are often excluded from the economy because of problems like this. And then the last slide, the only one I touched on here is the body cameras for state police officers. I know that we had discussed significant police reforms. This is not one of the ones that came out of the Police Reform Commission that was set up by the Speaker, but I had made a commitment to bring this bill back, and I will. And by and large, body cameras increase transparency. They increase trust within the community. And I think that they not only just protect citizens, but by and large, the data suggests it supports officers. And it has been good for officers. So that is all I had. Oh, no, I apologize. So last slide here, bond bills. These are opportunities for us as St. Mary's County residents to bring actual dollars through me and me sponsoring programs, dollars back here to our county. So the first one is for the Pax Naval Air Museum, which is a beautiful facility. When things get back to normal, I encourage you to go. But we are looking to do a small bond bill to help them out with some upgrades so that it is a better place for not just our residents, but for people who come here to visit. Because I know so many people come down here, and whether they're going to the base or they're participating in sports, they are checking out that museum, and I think this would go a long way. The next is for the Ridge Fire Department. They are looking to get a new boat, and we are going to do a couple things to help them out. But I'm also going to, the overall project is about $400,000 to $500,000. Rescue boats are not cheap, but we're going to do several things, and this will be one piece of the pie that we're going to put in and apply for and can support them. And then the last, the Lexington Park Health Department, if many of you didn't know that the PNC Bank, and not all this is out, but the PNC Bank has closed, and we're looking to possibly set up, a small clinic there, and this would provide a small surplus of funds to get them going and get it off the ground. The last, I'm going to actually encourage each and every one of you to reach out to the commissioners. Last session, we passed the bill, the Disabled Veterans Property Tax Credit. It basically expanded property tax credit for service members through categories. So the first, it's, before it was you had to be 100% disabled, and then you could take advantage of the tax credit. Well, now it says if you are between 50 and 74, you get a 25% tax credit. And if you're between 75 and 99%, we give you a 50% tax credit. This is, frankly, good for our community. And it now requires, we did the heavy lifting in Annapolis. It now requires the county commissioners to pass this legislation. for it to take effect. And this is important, for us. I mean, how many service members make up St. Mary's County? We put a lot on the line. There's a lot of wear and tear throughout the years. And frankly, this is a way to say thank you. And it's disrespectful to not pass this bill. Now, it's my bill. It doesn't matter what my disability rating is. I will never take advantage of this. But I do think that it is important for many of our members of our community who have put in the time and have suffered, some of them, significant injuries, given it all for this country, to take advantage of this. So with that, I'll answer a few questions. I don't want to, it's already 8:30, so we've been at, it's 8:37. So we've been at this for quite a while. But I want to answer a few of your questions. The first one is from Michael Blackwell, and he asked about the veto override of House Bill 1000, which that legislation was passed last year. It provides St. Mary's County Library with funding to eliminate overdue fines for all patrons and removing an inhibition on service for the less affluent. And, frankly, I think that this probably got struck down for some fiscal reasons with, not having a true outlook on it. And I will support that override because we should be giving back to the less affluent and those that are, working with our libraries. But if you have any other questions, Michael, don't hesitate to reach out, but I will be voting in support of the override. You had another question. Also, I just want to touch on this. You had another question regarding e-commerce and digital books. Please give me a call about that. I don't want to comment on his question really is, it requires a publisher licensing of digital books to consumers to license it at a reasonable terms to libraries. And without having seen a bill, I don't want to make any commitments because I haven't seen that. We got a question regarding Maryland Department of Tax Assessment and Taxation. And I think there's a little bit of misunderstanding here. The question was phrased as the Maryland Department of Assessment and Taxation announced an increase of 7.5% residential property and 9.7% commercial property in 2021. That is not a true statement. What they are saying is that property values, residential property values increased 7.5% and commercial properties increased 9.7%. So, obviously, yes, I get it. Property values are inextricably linked to the amount of dollars that you pay, but the tax rate did not increase. Additionally, you realize those gains in equity on the sale of the house. And I will take one more. So the Kerwin blueprint. Yep. So the Kerwin blueprint was the major education overhaul for the state last session. We had done a down payment, which gave teachers more money 2 years ago, and we saw those returns through retention. But it's really just an overhaul of the Maryland education system and the funding formulas that go into funding our students. And the question is really aimed at the total dollars and the local dollars that St. Mary's County residents would be required to pay. And currently, under current projections, St. Mary's County is slated to put about $139 million into into education. So there's a portion, let me back up here. There's a portion, about half of the education budget comes in from the state. The other half comes in from the local, and there's a small portion of that's federal, but that's irrelevant. There have been threats by local leaders that have said, we're going to have to raise taxes because of Kerwin. Under the current funding plan of Kerwin, our county commissioners will be required to put in $125 million by full implementation, which, you know, is slated, I think right now, 2030. As I had mentioned, we had already paid for it for 4 years up front, 5 years up front, till 2026. But the local share, St. Mary's County is already going to exceed that. So there will, as projected, we are putting in $13 million more than it would be required under the bill, and will not cost local taxpayers any more. And it's not a larger requirement. The one thing I would say about it is we could see after, you know, COVID and looking out beyond into 2022 and 2023, where we're not really sure what the fiscal impacts will be, you may see some things slide a year. So, you know, we were going to implement X, Y, and Z by 2022. Okay, maybe now that moves to 2023. I don't know if we will move the full implementation to the right. But my guess is the 10-year implementation plan probably sticks. Don't, you know, that's just my opinion. And we probably jostle some of the years in between to soften the blow in case there's any kind of fiscal impact that we're not projected for. But I do expect Kerwin bill, especially with an $800 million surplus, to fully pass. And you know, that I think when the override took place, again, we were looking at the $2.9 billion revenue shortfall. And now we're looking at an $800 million surplus. And you already have half of it paid for through a down payment. So, you know, from the state's perspective, we are in good financial standing, and I do foresee the Kerwin blueprint passing. Maybe minor changes, but overall, I do expect it. And with that, it's 8:45. I really appreciate everybody's time. I want to thank all of you for joining us tonight. I want to thank all of you for everything that you've done in our community. I hope everybody stays safe. And if you have any other questions, please shoot them to us. You know, we're here to help, whether it's unemployment claims or just general questions about our community. But thank you all again, and I really appreciate your time tonight.